years working in recording in progress. So she's been serving for 21 years in the field, focusing particularly on trauma and post-traumatic stress disorder. I've been fortunate to know her for the past 5 years through Places for People, although she's been with the agency since 2010. And she's currently a staff psychologist here. And in this capacity, she provides clinical services, cognitive processing therapy. She conducts research and has been providing training work in trauma, PTSD, and serious mental illnesses such as bipolar disorder, major depression, or schizophrenia spectrum disorders. And her clinical research focus really stems from her work with Dr. Patty Rezick, the developer of cognitive processing therapy, with whom she worked for 10 years through the University of Missouri at St. Louis. She served as principal investigator and co-principal investigator for several federally funded NIDA and NIMH grants, which explored effective treatments for people with substance use and post-traumatic stress disorders. And more recently, her current work, which is in progress now, has addressed how to ameliorate post-traumatic stress symptoms in adults with psychotic disorders in particular. And her presentation today will provide an overview of those empirically and theoretically meaningful considerations for understanding co-occurring PTSD and serious mental illness. So excited that she's able to be here to present today. And I think this work aligns very well with Illume's overall mission of being able to share the best available evidence we have to improve the quality of life of people with behavioral health disorders. So with that, all of you, take it away.
Thanks, Nathan. Pleasure to be here. Welcome. This is a lengthy webinar, and I'll try and go at a steady clip. So jot down questions for the end if you need to, and I'll try and remain as true to the objectives of this webinar as possible. So trauma and PTSD and serious mental illness. The objectives are you learn about some basic definitions for SMI. I use the term SMI for serious mental illness, trauma and PTSD for post-traumatic stress disorder. The second one is the theories of PTSD. Third is the therapies for PTSD in the field. Then the treatment outcome literature for PTSD and serious mental illness, which isn't really that vast. And lastly, some of my cognitive processing therapy findings for the application of cognitive processing therapy, which is CPT, for PTSD in serious mental illness. So those are the objectives. So what is serious mental illness? Serious mental illness refers to a smaller and more severe subset of all mental illnesses. So basically, it's mental, behavioral, or emotional disorder, which results in serious functional impairment. So that's a criterion, serious functional impairment, which interferes with one or more major life activities. So for example, if you have major depression, and one of the symptoms, which can be a serious problem, is concentration difficulties, then the concentration problems can interfere with reading. And if your life goal is to go ahead and study and get a GED, then there's some interference in that. So that would be an example of meeting all the criteria for SMI. The most common diagnoses include schizophrenia spectrum disorders, bipolar disorder, either major depression or severe treatment refractory depression. For a more detailed treatise, you can go to the SAMHSA website. SAMHSA stands for Substance Abuse Mental Health Services Administration. And the link is, the URL is given below. On the bottom of the slide, you have all the slides, so you should be able to refer to it anytime. What is trauma? So again, SAMHSA definition, trauma results from an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the functioning and physical, social, emotional, spiritual well-being of the individual. So that's pretty straightforward. It echoes what we just talked about as far as having a set of symptoms which impair functioning, which then interferes with our state of being. So trauma and SMI prevalence rates, basically, when we look at mood disorders and schizophrenia, the range can be anywhere from 49 to 100%. And general population rates are around 56. So if you look at interpersonal trauma as almost 100%, then half of the general population has almost half the rate. So prevalence rates are very high. And there are some gender differences. Women show a higher prevalence of sexual abuse and schizophrenia spectrum disorder, bipolar disorder, and mixed diagnosis groups labeled as having SMI. Also, women are more likely to have experienced domestic violence, being stalked, and witnessing domestic violence. As far as men are concerned, likely to have experienced warfare, robbery, stranger assault, witnessing stranger assault, and being threatened. And when you look at post-traumatic stress disorder that emanates from experiencing interpersonal trauma, basically the predictors are cumulative trauma, meaning the number of different types of trauma. So the more the number of traumas that a person experiences, the more the likelihood of PTSD, and that's followed by childhood sexual abuse. So what is PTSD? DSM-5 is a diagnostic statistical manual, which was basically the last version's 2013. And it says you have to have experienced a criterion A event, and then the symptoms that you experience as a result of the criterion A event are re-experiencing, persistent avoidance of trauma-related stimuli, negative alterations in cognitions and mood associated with the traumatic event, which is the criterion A stressor, and marked alterations in arousal and reactivity associated with the stressor. So let's look at the definition a bit more closely. So when we look at criterion A, which is a trauma stressor, and one is required, and there's basically exposure to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. So basically there's a threat to your integrity, physical. Direct exposure, witnessing, indirectly by learning that something's happened to a close relative or close friend. And if the event involved actual or threatened death, it has to be violent or accidental. Repeated or extreme indirect exposure to aversive details of the event in the course of professional duties. So it gives you examples like first responders collecting body parts and professionals repeatedly exposed to details of childhood abuse. So criterion B is re-experiencing, and one is required, and therefore 1 out of 4 required. So basically recurrent, involuntary, and intrusive memories, so like traumatic nightmares, dissociative reactions, example, flashbacks, intense or prolonged distress after exposure to traumatic reminders. So that's subjective feelings, basically, of distress. Marked physiological reactivity after exposure to trauma-related stimuli. So these are objective indices like heart pounding, sweating, shallow breathing, shallow and fast breathing, and the fight or flight response sort of stuff. Criterion C is avoidance, where 1 out of 2 are required. So basically you have trauma-related thoughts or feelings, which are internal. And then you have trauma-related external reminders, which are people, places, conversations, activities, objects, or situations.
So things that people are avoiding.
Right. So for example, trauma-related thoughts or feelings, these are intrusive thoughts, which don't make sense to us because they don't fit into our pre-existing beliefs. So one example that we talk about with our clients is, now for the next 1 minute to try and not to think about a pink elephant. And then they come back and say, well, I'm thinking about the pink elephant. It keeps popping into my mind. So that's an example of an intrusive thought. External reminders could be, I don't want to go back to the shopping mall because that's where I got assaulted. And so now all shopping malls are dangerous. So that would be an example of an external reminder. So criterion D is negative alterations in cognitions and mood, 2 required. And so these have to do with inability to recall key features of the trauma, which is not due to some organic condition like head injury or alcohol or drugs. You can have persistent negative beliefs and expectations about oneself or the world. So self-blame stuff, I'm bad, which comes in the next item. Distorted blame of self or others. It was my fault. Trauma-related emotions, which are negative: fear, horror, anger, guilt, or shame. Diminished interest or anhedonia. Feeling detached or estranged and not able to experience positive emotions. Criterion E is alterations and arousal. So 2 required: feeling irritable, self-destructive, or reckless behavior. So example of self-destructive might be mixing alcohol with meds. Reckless could be driving under the influence of alcohol. Hypervigilance, exaggerated startle. Concentration problems, sleep disturbance, whether it's onset, maintenance, or early awakenings. So the persistence of symptoms for more than a month, and there has to be functional impairment, social, occupational. I'll give you an example of that. Exclusion, so not due to meds or substance use or any other illness. And you need to say if it's dissociative subtype, if it is depersonalization, derealization. So, excuse me, depersonalization could be when you don't feel connected with yourself. Derealization is when you feel cut off from the world.
So Pallavi, just before we move on, because it's a question that's specific to PTSD diagnosis, someone asked, for criterion A, why does indirect non-professional exposure like electronic media, television, movies not act as a trauma stressor? Is there any research going on about this in PTSD?
No, I think it's just the way it's set up by the DSM that needs to be direct exposure to threatened or actual threat. So they don't really consider electronic media as a direct threat of fitting that, criterion.
Mm-hmm.
Yeah, sorry, I skipped over that bit. PTSD and SMI, rates of current PTSD in the SMI range from 29 to 43%. And the rates are higher when you look at patients with PTSD with schizophrenia spectrum disorder. So that can go up to 57%. In contrast, rates of current PTSD in the general sample are around 3%. And lifetime is around 12.5. Women with psychosis spectrum disorders have an elevated vulnerability to PTSD as compared to women who have a non-psychotic SMI.
So we know when we're dealing with SMI, with clients who have severe mental illness, like PTSD is just so prominent.
Yeah, that's just the rate of the interpersonal trauma and the PTSD, and then also the substance use is the other one, big one, which we're not going to talk about today. Theories of PTSD, emotion processing theory. So this is the underpinning for prolonged exposure therapy. And Foa and Kozak in '86 posited that there's a fear network established in memory during trauma exposure, which comprises of stimulus information. So that's basically, for example, a rape victim might say, the perpetrator is the stimulus, and it was a man, so all men are dangerous, so men become the stimulus. Reactivity, so that could be men are dangerous, behavioral, so avoid men, physiological reactions, when I see a man, I start sweating. Interpretation, linking the stimulus and response elements, I'm in danger when I'm in the presence of a man. So these are just examples of stimulus and response and interpretations that connect the stimulus and responses. They found that the more rigid the beliefs, the greater the likelihood of PTSD. And the therapy that emanates, like I said, from this theory is prolonged exposure, where you elaborate and contextualize the memories. And basically, as you do that, there's habituation of the response, reactivity, and change in cognitions. So I'll explain that a little bit in the next slide. Prolonged exposure therapy stipulates imaginal exposure, which entails repeated revisiting and recounting of distressing trauma memories. This is followed by 15 to 20 minutes of processing in which the imaginal exposure experience and other related emotions and perceptions are discussed. So the stimuli and the response and the interpretation. In vivo exposure has to do with approaching safe trauma-related situations. So for example, the shopping mall example that I gave you, you could start off with approaching a distant mall and a proximal mall. The idea is, as you talk about the memory of what happened, your reactivity starts to decrease, not only within the session during the exposure, but also across sessions as a result of the in vivo exposure. As the habituation occurs, your interpretation of what happened might change, but you might say, okay, so talking about the memory is not the same as being assaulted all over again. I'm okay, and I'm going to be safe, and this is an okay situation to be in a mall, because the mall didn't assault me, it was the perpetrator. Also, not all men are dangerous because it was the perpetrator. So you make some of these cognitive shifts, and it's the cognitive shifts that lead to a reduction in PTSD symptoms. So that's PE. Cognitive theory of PTSD has to do with cognitions, which are thoughts, and basically this model says that PTSD develops and is maintained by excessively negative appraisals of ongoing current threat that persists long after the traumatic event has transpired. So when you continue to view a situation as dangerous, and that's your appraisal, which persists and leads to intrusive thoughts and avoidance. And the more you avoid, the more the thought comes back in, like we talked about the pink elephant example. And that leads to distressing emotions, which can cause onset or maintenance of PTSD symptoms. So obviously the core treatment mechanism in cognitive theory of PTSD, or the cognitive model, is the change in dysfunctional appraisals of the trauma, which then predicts a change in PTSD symptoms. So the idea in cognitive behavioral therapy is to allow or help individuals to identify, examine, and change unhelpful thoughts about others, like people are not trustworthy, about themselves, which could be the self-blame, it's my fault that this happened, and the world, which is basically the world is dangerous. And it could also include examining and changing unhelpful behavioral responses that could perpetuate trauma symptoms and hamper functioning. So for example, not using a bus, drinking to promote sleep. A lot of the times you can do behavioral experiments to allow for the cognitive shift to occur. So for example, starting to use a bus and realizing that the odds of something happening are low, and then, you know, improving your functioning in that sense, as far as being able to get out and about. EMDR is the third one. And this is a structured protocol-driven trauma-focused therapy, which is based on the adaptive information processing model of PTSD. So the idea is that trauma is stored and stuck in the brain's neural network in a maladaptive way. And the therapy would involve recalling an image, thought, emotion, and a bodily sensation associated with the trauma while receiving bilateral stimulation, most commonly in the form of eye movements. And this, it's suggested that the bilateral stimulation aids in the processing and integration of traumatic memories in a more adaptive way. So moving on, what about PTSD and SMI? And what's the state of the literature there? So there's some evidence that cognitive behavior therapy models of PTSD apply to PTSD and SMI. But the idea is we need large-scale randomized controlled trials to figure out what modalities and techniques are associated with improvement. So the 4 randomized controlled trials that have been reported are Vandenberg 2015. So this one looked at comparing prolonged exposure therapy and EMDR therapy against a weightless condition. And both conditions were more likely to achieve a loss of diagnosis during treatment as compared to those in the weightless condition. Also, the gains were maintained at the 6-month follow-up.
So when you say loss of diagnosis, that means their PTSD symptoms improve enough they no longer meet
Right, they
criteria.
didn't meet criteria.
We have a question that says something specific about this. Okay. So someone mentioned that we're moving away from using this as research for EMDR is mixed in favor with other treatments with stronger evidence. Someone, yeah. So it's just one of the ones we're including as something that's has been used with individuals.
Right. I'm just reviewing the literature at the moment.
Yep. Thank you. Okay.
Muser and colleagues developed a structured cognitive behavior therapy program for treating PTSD and SMI. It's 12 to 16 sessions long, includes psychoeducation, breathing retraining, and cognitive restructuring. And there are 2 randomized controlled trials, 2008, where you compared the CBT program against treatment as usual, and 2015, where you compared the CBT program against something called the Breathe, which is a brief treatment program, and has been found to be an active treatment condition in and of itself. So the problem with the 2015 trial was that the prevalence rate for the psychotic spectrum disorders was pretty low. Well, only 1/3 of the sample were meeting criteria for a schizophrenia spectrum disorder. So basically, in an effort to determine the effectiveness of this protocol for the psychotic spectrum disorder, Steele et al. In 2017 conducted a randomized controlled trial of cognitive behavior therapy with treatment as usual, with a 6-month treatment phase and a 12-month follow-up phase. And the results of the Steele et al. Study basically did not show an effect size, significant effect size for the cognitive restructuring without direct exposure as compared to the treatment as usual. So next slide. Yeah, so basically these results are consistent with the meta-analysis which was done by Sin in Spain, and they found that the schizophrenia group wasn't showing a significant result with cognitive behavior therapy. And O'Driscoll said, maybe we need more emotional processing with cognitive restructuring. And Steele recommended that cognitive restructuring programs may require further adaptation for people who have PTSD with a psychotic spectrum disorder. And this conclusion would be consistent with the positive results obtained using direct memory exposure interventions like PE and EMDR for the treatment of PTSD and psychotic disorder. And basically, some of this was cited in the meta-analysis study by Gruborg et al. In 2021, where they found large effect sizes of PTSD outcomes among individuals with SMI with PE and EMDR. So, given some of these conclusions that perhaps we need to have emotional processing added to cognitive restructuring, I got interested in looking at cognitive processing therapy, which in its original form combines the concepts of cognitive restructuring and emotional processing. So the first edition manual is 1996, and the second revision came out in 2017. So I'll just briefly go over some of the basic tenets, and then the last part of the presentation will focus on the initial data that I'm finding using this particular therapy for treating PTSD and serious mental illness. So CPT is based on Mahoney's constructivist perspective. So the idea is, as a result of growing up and our experiences, which define our personal realities, we interpret the new experiences that are coming in to fit pre-existing determinations, which are called schemas. So when someone is exposed to schema discrepant information, one of two things can happen, assimilation or accommodation. So one is, okay, so the information could be assimilated into the pre-existing schema without the changing of prior beliefs. So for example, if you believe that only strangers rape, then you're raped by an acquaintance, you could say it wasn't a rape. Alternatively, pre-existing beliefs could be changed to incorporate the new discrepant information. For example, it is possible to be raped by someone you know. So this new learning is accommodation and is the goal in therapy. The therapy has an exposure component. Basically, it's written exposure. Clients write about what happened and they feel their feelings as they write, they read, and then they feel their feelings and figure out the stuck points. So these could be blind assumptions, leaps of logic, conflicting beliefs like we just discussed. And stuck points are categorized as assimilation, and Patty Research in her early work found that there was also some overgeneralization of beliefs, which they termed overaccommodation. So assimilation could be denial and self-blame. So basically, it was my fault. I did something to have brought this on myself. Overaccommodation could be something like overgeneralized belief, like all men are dangerous, the world is dangerous. And the idea is to challenge the stuck points through Socratic questioning, which is guided discovery, and use of daily worksheets. Once dysfunctional beliefs are deconstructed, more balanced self and other statements are generated and practiced. And these are the statements which are classified under the construct accommodation, which is the goal in therapy, like we just discussed. So some research with CPT basically decreases in assimilated and overaccommodated thoughts and increases in accommodated thoughts have been found to be related to symptom reduction as far as PTSD is concerned at post-treatment. And these findings have been shown for rape survivors and active duty service members with PTSD, and also been found to be true in long-term follow-ups for both PTSD and depression symptoms. In 2008, I helped write the study. Reexperiencing et al. Conducted a dismantling study, conducted a dismantling study of CPT. And the idea was to break it down and compare the cognitive restructuring component and the written account component with the original CPT exposure plus cognitive restructuring protocol. So obviously, CPT in all three conditions improved, and surprisingly, the combination, meaning the original protocol, didn't improve upon the results of either component. CPT-C, which is the cognitive restructuring, reported greater improvement than written exposure. Not that written exposure didn't do well, it's just that cognitive restructuring did better. And when you compare the CPT in its original form with CPT-C, the dropout rates for CPT-C were lower, so it was considered more parsimonious. And if you look at the second edition, it focuses basically on the CPT-C. However, it does include the written exposure bit in the appendix, like towards the end of the manual, the second edition manual. And the authors do recommend that don't toss it out, because there are going to be conditions where people need to reconstruct the event and or access emotions that have been particularly avoided. And so that could be if there's dissociation, substance use, and we know for a fact that both dissociation and substance use are very high in SMI.
So those are folks it's better to do the written exposure.
Yeah, exactly. So moving on. So given all this background, with Steele suggesting that exposure may be required with cognitive restructuring in order to treat PTSD, especially within the schizophrenia group, I thought I should collect some data using the CPT in its original form for the treatment of PTSD and SMI. So in the first study, there are two small studies. The first study, the idea was to see if the cognitions change from pre to post treatment. So stuff like assimilation, over accommodation, are those showing a shift? And the second goal was to see if changes in cognitions predict improvement in PTSD symptoms. So the first study was between 2015 and 2017. And I was looking at the feasibility and internal validity of the CPT with written account exposure, or written account for PTSD and SMI. And the study was conducted at Places for People. The study had 37 clients who met diagnostic criteria based on the DSM-4 TR. Essentially, if you look at the distribution of the diagnoses, same as the Muser 2015 study, where about 1/3 of the population or the sample had psychotic spectrum disorder as compared to the mood. So generally speaking, we had a lot more women, African American, and then single, less than high school, and $500 to $1,000 generally.
Lower income.
Yeah. High school, really, 31%. I was right. So I did a chi-square, and that was, well, no, actually the chi-square comes later. There were no significant differences between the dropouts and completers on the demographic variable. So it's not that the dropouts are showing any particular race or gender or marital status or education profile. Also, the dropout, which is around 38%, is generally comparable to the 34% reported for CPT in its original form in the Reexperiencing et al. Study, the dismantling study we talked about, the 2008 study. Index trauma, sexual assault, followed by death by murder, illness or suicide, followed by physical assault. So generally speaking, the interesting part in this slide is that on age, the completers are comparable to the dropouts. It's taking them almost twice as long to finish the therapy. So the one thing is, with the manual, it says do 2 sessions a week, which is what we were doing at UMSL. But given the logistical constraints at play with this population and the teams at Places for People who are providing logistical support, we pared down the sessions to once a week, and it still took them about twice as long, so almost 20 to 21 weeks to finish the protocol on average. And the chi-square didn't really show a differential dropout for the psychotic spectrum as compared to the mood or non-psychotic spectrum. Impact statements. The impact statement is something that they write about the account in the very beginning. And the idea is to write about the impact that the trauma has had on their beliefs about themselves, others, and the world. And what we tend to do is get the impact statement at pre and also at post, meaning session 12. So session 1 and session 12, and then those are coded, the accounts, for assimilation, which is self-blame related stuff, over accommodation, which are the overgeneralized beliefs, and accommodation. There's also a 4th category called information. So pre and post treatment impact statements were available for 13 completers. Pre-treatment impact statements were available for 5. So we couldn't get the post for them for some reason or another. And then pre-treatment impact statements were also available for dropouts, 11 dropouts. So the coding was done by me and Nathan Dell, and I rated the statements and the impact statement for information assimilation, accommodation, and over accommodation. Inter-rater reliability was around 0.64, which is generally good. And then did some analysis and found that there were no pre-treatment differences between the psychotic versus other disorders on the 4 information processing indicators for the impact statements. So no differences in pre-treatment. So we collapsed the sample across the 2 diagnostic categories and did some more analyses and basically found that dropouts are higher on self-blame and appear to be more symptomatic on self-blame when compared to completers. So that's the take-home message from this slide. I've tried to synthesize each slide and the numbers on the bottom so that it's easier to interpret. This slide basically shows the means for the 4 information processing indicators from pre to post treatment. And as you'll see, the self-blame tends to come down from 1.54 to 0.00. Information tends to come down, so they're not filling all their impact statements with a lot of fluff. Accommodation tends to go up, so the healthier beliefs, reconstructed beliefs tend to go up. Over accommodation, which is the overgeneralized stuff, also tends to come down. So things are going in the direction that you would expect them to go for this sample as a result of therapy. So basically, the first thing we said was, okay, it's feasible to do this protocol with treating PTSD in the SMI population, because a lot of the times when you look at the treatment outcome literature, SMI is an exclusionary criteria, especially the psychotic spectrum disorder. And we found that the 4 information processing indicators can be used to assess for changes in PTSD symptoms in persons diagnosed with SMI from pre to post treatment. So this leads us to study 2. And I was like, all right, so we know that things shift cognitively. And do these shifts predict treatment outcome as far as PTSD and depression symptoms and functioning? So this is a sample of 21. So here we have a more even distribution of African Americans and Caucasians. And the other stuff is comparable to the first study. And in diagnosis, which is the next slide, you find that we had greater number of mood disorders in the second study as compared to the first. So we know that base rates for the psychotic spectrum disorders are low, but the second study was lower. Index traumas are the same. And number of weeks to completion is comparable. Number of sessions to dropout for the dropouts is comparable, like between session 4 and 5. So this this just shows that there are no differences on pre-treatment PTSD scores as assessed by the PCL-5, which is the PTSD checklist for DSM-5. As you can see, the mean scores are pretty high, 51.18 for the completers and 52.33 for the dropouts.
Can you remind people what's the cutoff for PTSD diagnosis?
Yeah, so generally a score of 30 or so is considered the cutoff for the PTSD diagnosis.
These people have a lot
Mhm.
of symptoms.
Yeah. Same thing with depression, they're comparable. So what we're saying is that it's not that the more severe symptomatic people dropped out, and so we're looking at an easier group. They're all very comparable to each other on PTSD and depression. As far as scores on functioning, high scores on BPRS indicate more severity of psychiatric functioning. BPRS is Brief Psychiatric Rating Scale, and HUDAS is the World Health Organization Disability Assessment Scale, which basically is now being used as opposed to the GAF. No significant differences between the completers and dropout on the pre-treatment functioning scores either. So now we looked at, okay, what about as a result of therapy? Do things improve? So PCL5 scores went down significantly. So as you can see, 51.20 to 17.90, PHQ-9, 17.9 to 5. So significant decrease.
That's amazing.
Yeah, good
I mean,
scores.
that's like phenomenal change.
Yeah. And then BPRS scores went down significantly so, and HUDAS scores. So these scores are basically impairment in functioning. So you find a reduction in the impairment in functioning. So moving along, I did a regression to see which ones of these 4 information processing indicators seems to predict the change in scores for PCL5, which is the PTSD scale, and assimilation, which is self-blame, showed, the closest thing to significance. So basically, there was a significant trend for the prediction of difference in PTSD symptom scores from pre to post treatment for completers by basically the self-blame improvement.
Sorry.
So completers improve from pre to post treatment on symptom measures. Completers improve from pre to post treatment on functioning measures. And resolution of self-blame seems to predict improvement in PTSD symptoms. Those are the conclusions. Now, the problem with this study, like we said, was that there was hardly any, meaning the treatment outcome stuff. We need more psychotic spectrum disorder people who have PTSD for the outcome measures. And we're continuing to do that work. So collecting more data. So look out for study number 3, which will have some more information. We do know that cognitive shifts occur, and we don't have cognitive rigidity in the psychotic spectrum disorders, and things do shift. We just need to show a direct link between the shift and outcome for the psychotic spectrum disorder. So moving along in that direction, that's work in progress. Thought I'd include all the references so you could look at them at leisure if you wanted to go back and check out any of these studies. There's also a web-based training, which is self-paced, based on the 2nd edition of the manual, which is more heavily weighted towards the CPT with cognitive restructuring, but does include some of the homework practice stuff for the written exposure towards the end. Also, I'll be providing CPT training through the Center of Excellence at Places for People under the umbrella of Illume on December the 2nd and 3rd. So basically, that's the link. And there's a slide, I think there's the last slide that talks about it as far as where and how, and material includes training books, materials, CEUs, etc. That's fine.
Yeah. Now, and that will be, like it says, a 2-day training with a lot of emphasis on thinking about providing CPT specifically to an SMI population, because that's.
Yeah, also, I think by then, right now I have, I'm seeing, well, I don't know how to put it, but my numbers will increase as well as far as the psychotic spectrum disorder group. And so for the skeptics, hopefully we'll have some treatment outcome data. But we've already shown that shifts do occur.
Okay, we have a couple questions here.
Yeah, so the copy of the PowerPoint, I believe, was sent out to all the registrants, but
right, but if you, I see this from Robin, if you did not get a copy, I know Kizzy sent copies out yesterday. So maybe check your email, and if you did not get one, just let us know and we will send you a copy of the PowerPoints, because we did send those out to people who registered yesterday. We have a couple of other questions. One was just asking about noticing that the sample size in the SMI studies are kind of small.
Well, yeah, these are preliminary studies. And the other thing is working on a grant, and it's got excellent reviews. And so hopefully revising and resubmitting by next year, by which time I'll also have some of the treatment outcome data. for the psychotic spectrum disorders. So once we get a randomized controlled trial funded, it'd be nice to be able to show some of these findings on a larger scale. Also trying to establish relationships with some of the community stakeholders to see if we can't propose a multi-site study, and that will really improve the feasibility of the data collection with this population, given the low base rates for psychotic spectrum disorders.
So there's another question here. Anybody else who has, we have a lot of time, so anybody else who has questions, please go ahead and pop them in the Q&A. Someone was asking about noticing that the death by murder, illness, suicide was at 18% in study number 2, but complicated bereavement was at 0. Can you elaborate on how these categories were calculated and separated?
Can we go back to that slide? Study 2?
Yeah.
Just want to look at it.
Yeah, so let me go back. Let me close my questions. And then after you do that, I had a couple of things, but please drop in more questions if you have questions. So I'm not sure what slide that was on. Is that on here?
Yeah, keep going.
Back or forward?
Back. Yeah. So complicated bereavement, 0, the physical assault. I think I was using the trauma screen questionnaire as a precursor to the PCL5. And that has 17 questions. That's a Kubeni measure. So I can send it to you, and it's got these different categories. So that's how it panned out.
Okay, and I enter other questions if you guys have them. One thing I noticed when you were, or that struck me when you were talking about the biggest difference, right, between the completers and the non-completers, were that self-blame beforehand, and that just really, you know, like, are there ways to kind of, or interventions that we can maybe think of when we have identified that someone is higher in that self-blame area, or things that we could do that maybe would increase engagement with those folks so they're less likely to drop out? Because that seemed like the strong indicator for dropout, right? And this is not like research, this is just sort of brainstorming as clinicians.
I'm not sure if it was the self-blame that was leading to the dropout, as much as the dropouts had slightly higher self-blame, because it was the resolution of self-blame that at the end of the day that also predicted the most improvement. I think the bigger question for me, given this slideshow, is that the dropouts, when they do occur around sessions 4 and 5. So if you look at the CPT manual in its original form, that's around when they're doing the writing exposure. So how do you retain them and improve engagement without losing them? And that's the part where you get some avoidance and you have to really stay on top of it. So I think the clinical implication is, how do you retain most of your people by addressing some of the stuff around the exposure part of it? Because like the 2008 study showed, the dropout for CPT in its original form was higher than CPT with the cognitive restructuring alone. And that's why the conclusion was that, okay, maybe CPTC is more parsimonious, it's showing equal effects and lower dropout. So when you know that exposure is important and is meaningful, and when they get through it, they do get better, as you know, with the SMI population, then I would want to focus more on that. You know what I'm saying?
So maybe this is along those same lines, and I don't want to put you on the spot, but what are your thoughts about why the written exposure part is more effective or plays a bigger role in the SMI population for CPT?
Yeah,
in general?
that's a good question. Is it a question or
Yes,
is it you asking
that's
me?
my question.
Oh. So the one thing, like if you remember, Reexperiencing et al. Concluded in the second edition that don't throw the baby out of the bathwater, because you could need the exposure for people who are more avoidant and who are not avoiding or engaging with their emotions. So one thing we do know is that the SMI group has a larger incidence and prevalence rate of dissociative disorders as well as substance use disorders. And those both have to do with disengagement and avoidance. So what is the question?
Just about those ideas about why the written exposure is
Yeah.
more effective.
So you need the written exposure so they can feel their feelings. And in addition to feeling the feelings, the one thing we ask them to do when they're writing the narrative is to draw a line wherever they get stuck, where they have to stop and go back to it. So basically, the goal is to draw a line and bring it back into the session. And then you explore what led to you having to stop and why did you have to take a break. And generally speaking, there's avoidance around that. And whenever there's avoidance, there's a stuck point behind it. So you can isolate and flesh it out and then target it more specifically using the cognitive restructuring methods.
Do you know if there's much work being done on, you might not know this, so it's really just genuinely asking, much work being done on research around any of those other trauma treatments, specifically with SMI, or like the work with CPT?
I think there's one group, which I was talking to Kim Muser, and he said that this is a Dutch group that's looking at cognitive behavior therapy as developed by him, the 12 to 16 session protocol against prolonged exposure. So that's the only one I'm aware of at the moment.
Okay, so, and I also have another thing, since people aren't putting stuff in and I can always find stuff to talk about. Thinking about, on the one hand, for your studies, the N is small, right? The number is kind of small. And I think like it's interesting to think about that balance of the very structured randomized studies and how important those are for developing an evidence base. And at the same time, some of these smaller studies about like the real world application, because your experience with it is very based in real world application, and those learning about how it takes a lot, like it might take twice as long to get through the protocol with this population, and some of the flexibility that those sort of studies provide versus like, this is it, like you have 12 sessions period, or you have this amount of time. So I don't know, it feels to me like that blend of both the randomized controlled trials with research or data from real world experience kind of actually blend to provide a best case scenario of looking at.
Yeah, I mean, I think what you're getting to is how do you adapt a protocol? So one thing we did was stretch it out once a week to address the logistical constraints.
Right, and I love the idea of adapting it, but collecting the data as you adapt it, because I think sometimes we get evidence-based practices and then we bring them into our real world scenarios and we just kind of have to adapt them, but we never collect the data on whether our adaptations are helping or hurting, and then so I mean, I love that we're continuing even as we're adapting it in real world to collect data around it so we can understand if it's still working and maybe what is it about the adaptations that are making it more useful.
Because I remember a dialogue with Patty Reesick, and she said, why aren't you doing 2 sessions a week like it's supposed to be done? And I said, well, I mean, that's really logistically impossible. And then in the meantime, we're getting good results. Of course, it's still work in progress, but if you can get good results while adapting to the client's needs as far as all the difficulties that they have with the day-to-day, being able to function and being able to come into the session and all the obstacles that they face, then why not? If you're getting the same results, like good results.
Right. And make it work for the person.
Yeah, because she was worried that the avoidance might creep in or they might drop out more but dropouts are comparable. Like we saw the 2008 study and my study, they were like 34%. Of course, it's higher than CPTC or, but in the meantime, if CT alone is not working, meaning cognitive restructuring is not working when the CBT protocols like the MUSA studies showed,
Right.
then why not try adapting?
Mhm. And so I don't want to put you on the spot. Oh, here's another question. In your experience working with persons served, when PTSD symptoms are able to be decreased, does this also decrease their SMI symptoms? For example, treating PTSD, decreasing psychotic features of schizophrenia.
The positive symptoms of schizophrenia you would expect are contained with the meds, and they need to be stable on the meds. But the negative symptoms, like some of the stuff, there's some overlap, like detachment and estrangement, social withdrawal, avolition, anhedonia. So those are all like there's some overlap, and so some of that stuff was tapped into by the BPRS, which we showed as having shown improvement in functioning. So to a certain extent, yes, but I think meds are important too.
Right. But yeah, that one slide really did show a lot of symptoms that wouldn't necessarily be thought of as exclusively PTSD symptoms that are still improving.
Right.
And then a lot of people no longer even meet PTSD criteria.
Yes.
Awesome. Yeah, thank you. So would you mind just briefly talking about the breathe, since we have a few minutes, and what that is? Because I think there's a lot of people who haven't heard of that.
Oh, so breathe is the control condition that Kim Muser was using in his 2015 study when he was comparing his cognitive behavior therapy protocol with the breathe. And breathe stands for brief relaxation, education, and trauma healing. And basically it's 3 sessions long. So the first session is essentially coping strategies like breathing retraining. And the second and third session have to do with psychoeducation regarding PTSD and psychoeducation regarding related symptoms of PTSD. And so it's only 3 sessions long, but it did really well, where the results, if you combine the results of the 2008 and the 2015 studies, the findings with breathe fell somewhere in between treatment as usual, which was a control condition, and CBT, which was the cognitive behavior therapy condition. But I mean, I was just talking to him very recently, and he said that breathe caught up in a year, even on the PTSD symptoms. So I don't know, I haven't looked at the data yet.
But yeah, so
but it's a very effective, like it's found to be an active intervention in and of itself. So that's brilliant.
Right. And it's a lot of people are able to complete it because it's only 3 sessions.
Yeah.
And really get benefits. So.
Yeah.
And that
of
is
course
also,
it doesn't do, I mean, yeah, okay.
No, go ahead. It
No, go ahead.
No, I was just gonna say another little plug that is also an intervention that you train on, and we've done some trainings with local agencies, some in-house staff here at Places for People, but we've also trained a couple other agencies on breathe, and
right.
If anybody's interested in it, you can reach out to us for that too. That could be something that we could work with you on.
Yeah, I think he found interesting finds with PTCI, which is a post-trauma cognitions inventory, like shifts in that and depression. And then he said the PTSD seemed to have caught up in a year, but I don't know. I haven't seen those numbers. So
right. So we're just saying what Kim said. We're not validating that data point, but it is nice to know that there is a simpler intervention that maybe, and it can be a nice step into like CPT or other treatments to help people get some sense of success and experience in therapy. And they might be willing to join a 3-session treatment before they're willing to buy into
a 12 session
that might turn into 20 20 weeks or something. And that like to get that success with therapy under their belt is really increases the possibility that someone will join a more in-depth therapy.
I had collected some data with breathe, which was a small sample which we published in Psychiatric Rehabilitation Journal, and that was back in 2015. But since then, he's obviously had the randomized controlled trial and shown some findings. So
Yeah. So I don't see any more questions. I know we're early, but I'm sure nobody minds ending early.
yeah.
So if anybody else has a question or comment, please drop it in quick. Otherwise, I'm going to turn stuff over to Kara so you can help us wrap up here.
Sounds good. I was just going to share some of our upcoming webinars, but first I just really want to thank Paul V and Julie for all the information shared today. I know I learned a ton. Can you all see the PowerPoint that I have up on the screen?
Yeah.
Okay.
Yes.
Oh, is that in presentation mode? I hope not.
Yeah.
Anyway, just first off in the far right corner, you'll see the survey link that we have today. It will pop up when you all leave, but if anybody wanted to pull it up on their phone, there is a QR code that you can pull it up on your camera if that would be the way that you want to fill out the survey for today. But for our other upcoming webinars, I know the one at the bottom that Paula V already talked about that she's doing in September, which is a very more expanded view of what she's talked about today, which is CPT with PTSD and SMI. That will be the first week of December. You can sign up for that and all these other ones on it's placed for people's website under Center of Excellence on our events page. And you can find out more about all these webinars. Our first one that's coming up is Black Girl Blue, which will be next week. And we're really looking forward to that. And it is actually a film from a local filmmaker, and she's been on several platforms and won several awards, and she's entered into a couple other festivals. And it's around Black women struggle with mental health and the stigma around it. And so we'll be having a directors panel with the director, one of the women that is involved in the film, and a couple of Place for People staff member. So that will be next week. We're having the ability for people to come in person and also over Zoom for that one. And then the rest of our webinars for the year will be just over Zoom. But we really look forward to them and hope y'all can make it, and feel free to reach out to us if you have any questions about them. And looking forward to hearing your feedback from today on the survey. As I said, again, you can feel free to do that with that QR code, or when you click out, it should pop up. But if you have any more questions from today, let us know. You can email, I think Kizzy's been emailing you all about the event, or you can reach out to me. My email should be on the Center of Excellence website. Or maybe you've received an email from me a time or two. So we really thank you all for coming out today. If there are no more questions, I think that's all we have.
Yes.
Well, I just wanted to take a minute and thank everyone for attending. I know it's a beautiful day outside, so
Yeah.
thank you for your time.
Thank you, everybody. We really appreciate your time and attention.
And like Kara said, please feel free to email me if you have direct questions regarding any of this, or Breathe.
Sure. I think someone asked, how can I sign up? Let me put the link for
And I'll put all of these.
our trainings. So here's a link for our training. Well, that's not the. So there's a link to all of our trainings. I don't know if there was a specific training that the person that typed that question was looking for, but that should be a link to all of the trainings coming up.
All right. Thank you, everybody.
Thank you.